Welcome everyone to June DUR meeting. Just a friendly reminder, everyone that's not the member of the board, please enter your contact information into the chat. And the board, please, if any question, please preserve until the end of the presentations for any questions. Any feedback, please send it to medicaidpharmacy@utah.gov. And with that, I leave it to Dr. Kennan. You are on mute.
That's perfect. It's just like normal at home talking to myself. Thank you everyone for getting up early, and welcome to the DUR board here on the June 13th. Everybody should have received a copy of the minutes. Do we have any questions, changes, or recommendations around the minutes from the previous meeting? All right, hearing none, do we have a motion to approve?
So moved.
Thank you. So we have a motion from Catherine. Do we have a second?
I'll second.
Thank you, Dr. Siegfried. We have a motion and a second. All in favor? Aye.
Aye.
Any opposed? All right, those motions pass. Noon, do we have any housekeeping?
Yes, we do have a couple housekeeping. The first housekeeping item is it was brought to the state attention from the last DUR that is a little bit difficult to have the discussions when people don't have the camera on. So it's a friendly reminder to people on the meetings if it's possible to have your camera on so that we can gain the emotions from people so that we can have the discussions smoothly. And the state appreciates that if you can turn the camera on if possible. Thank you very much. And then Sapide, would you like to give the update as well?
Yes, good morning all. So I just wanted to give some update regarding the Change Healthcare outage. So as you know, it was from February 21st, the cyber attack happened with the Change Health. And it is a multi-phase process to restore the system. Now we are in the new phase. We are going to get some update with the drug files, and hopefully by Monday, the providers are able to access the PDL from their interface. Is not going to be big changes, but all drug file updates will be completed at the point of sale system POS with the correct effective dates from the beginning the outage. So that's the new update. It is not fully functionable. Still, as I said, it's multi-phase, but we are getting there. There is no ETA that when we are going completely go back to the fully functional system. Hopefully soon. Thank you.
Thank you, Sapide. And the last housekeeping item is for the NEO CMS DUR survey. One of the ACO has submitted their survey to the state. The state in the process of review those answers. And the state is in the process of finish the fee for service portions. And we will be submitting this report to the CMS by the deadline of June 30th of this year. The report will be available to review sometime next year on CMS website. And that's all the housekeeping items.
Great. Thank you, Noon. Brian, do you have an update on P&T for us?
Yeah, at the May P&T committee meeting, we finished our series talking about the anti-VEGF treatments with a review of the oral anti-VEGF agents. And at our next meeting in September, we will be discussing treatments for hereditary angioedema. And we'll also have our annual ACO updates at that meeting as well.
That's great. Thank you, Brian. Moving on in our agenda, we now will turn it over to the University of Utah for a discussion on concurrent use of opioids with muscle relaxants and hypnotics. So not certain who from the university is going to be presenting, but we'll turn the time over to them now.
You're stuck with me this morning. Hopefully you can see the presentation. So good morning, everyone. The goal of today's presentation is to discuss evidence for the risk of respiratory depression from the concurrent use of prescription opioids with muscle relaxants and/or sedative hypnotics, and to review utilization data for past year concomitant use in the Utah Medicaid fee-for-service population. Opioids are a heterogeneous class of compounds that includes 23 unique prescription opioids. Many opioids are available in multiple formulations, including oral, transdermal, or injectable products, and long-acting and/or short-acting oral formulations of the same opioid. Opioids are primarily prescribed to treat acute or chronic moderate to severe pain, although some of them can also be used to treat cough, diarrhea, or opioid use disorder. By impairing signals from the Central Respiratory Control Center and several other mechanisms, all opioids can impair respiration, potentially leading to hypoventilation and inadequate gas exchange in the lungs called respiratory depression, abbreviated RD. RD is often, but not always, preceded by increased sedation. Opioid-related mortality is primarily attributed to overdose resulting from RD. Due to pharmacodynamic and pharmacokinetic differences, certain opioids may have a higher relative propensity for RD, such as fentanyl or methadone, while others may have a lower relative propensity, such as buprenorphine or tramadol. In recent years, most opioid-related deaths involved the misuse of illicit or diverted synthetic opioids like fentanyl, with fewer deaths attributed to prescription opioid use. Since 2010, the number of opioid overdose deaths increased despite declines in the average number of opioid prescriptions and the average prescribed opioid dose, perhaps suggesting that reducing opioid access for patients with ongoing pain may not be protective of opioid overdose, considering it can place patients in a desperate situation. Over the years, many policies have been implemented to promote the judicious and safe use of opioids. In 2016, the FDA required opioid analgesic and cough products to carry a black box warning for the increased risk of RD and death when opioids are used concurrently with central nervous system, abbreviated CNS, depressants. The FDA's evidence review supporting this warning primarily found evidence showing increased risk from concurrent use of benzodiazepines with opioid analgesics. Due to similarities in pharmacologic properties, the FDA extended this warning to opioid cough products and all CNS depressants. Non-benzodiazepine muscle relaxants and sedative hypnotics were among drug classes listed as examples of CNS depressants by the FDA. The FDA cited one descriptive study that mentioned muscle relaxants, and this study described that opioids were involved in 17% of overdose deaths attributed to muscle relaxants. Notably, we cannot be certain that the implicated opioids were prescription opioids or opioids from illicit or diverted sources. Our review addresses non-benzodiazepine and non-barbiturate muscle relaxants, and abbreviated MRs, and sedative hypnotics, abbreviated SHs. We included 9 different MRs with variable mechanisms of action. Most MRs are FDA indicated for the acute treatment of musculoskeletal spasms and/or pain, except for baclofen, dantrolene, and tizanidine, which are indicated to treat spasticity. Reviewed SHs are classified into 4 drug classes: non-benzodiazepine benzodiazepine receptor agonists, or Z drugs, melatonin receptor agonists, abbreviated MRAs, orexin receptor antagonists, and histamine receptor antagonists and tricyclic antidepressant. The reviewed SHs are FDA indicated for treatment of sleep onset and/or sleep maintenance insomnia, except for the MRA tasmelteon that is indicated for rare non-insomnia sleep disorders. Recent U.S. guidelines for the treatment of chronic insomnia in adults prefer cognitive behavioral therapy, abbreviated CBT, as first-line treatment for insomnia, although it may not be accessible to or effective for all patients. Guidelines recognize most of these medications as options for chronic insomnia, including for chronic therapy in adults who fail or cannot access CBT and who continue to benefit from treatment during regular follow-up, according to the American Academy of Sleep Medicine. To examine the risks of RD or overdose from concurrent use of opioids with CNS depressants in general, or SHs or MRs specifically, we reviewed recent pain-focused guidelines prescribing information for representative opioids, SHs, and MRs, drug safety communications from the FDA, Lexi-drug interactions, and select expert opinion reviews. Additionally, we reviewed a recent systematic review and meta-analysis, abbreviated SRMA, of observational studies by Wang et al. On the predictors of opioid overdose. I will highlight information from these sources on the following slides. Overall, the reviewed evidence considers all MRs and SHs to be CNS depressants with a theoretical or observed potential to increase opioid-related safety risks. Some CNS depressants may directly depress respiratory drive, and others could impact other respiratory processes. Due to respiratory differences during wakefulness versus sleep, hypnotics may indirectly impair respiration through changes to sleep architecture while asleep. Subtle changes in respiration from CNS depressants may become clinically significant in certain populations, including people with sensitive comorbidities like sleep apnea or in those taking opioids concurrently. Separate from the black box warning for the risks from concurrent use with CNS depressants and opioids, opioid prescribing information warns that opioids can potentiate the neuromuscular effects of MRs, enhancing the risk of RD. The recent SRMA of observational studies, including patients with or without substance use disorder by Wang et al., showed that use of either an SH or MR as a class with an opioid was associated with a modestly increased adjusted odds of fatal or non-fatal opioid overdose compared to not using those agents with an opioid. The point estimate for the association with overdose was slightly higher for concurrent use with benzodiazepines compared to MRs or SHs, although the confidence intervals still overlap. Primary studies contributing data to the SH or MR categories provided little information about which specific MR or SH agents were included in the study, although we infer that they most likely did not include benzodiazepines in those categories. Thus, we cannot be sure the estimates are representative of all our reviewed SRs or MRs, or SHs or MRs, or if it includes effects from benzodiazepines. While reviewed guidelines and FDA safety guidance tend to treat non-benzodiazepine CNS depressants uniformly regarding the risks with concurrent use with opioids, the agents have heterogeneous properties, and therefore we infer that the magnitude of interaction with opioids could vary by drug class or agent. However, the comparative empirical evidence between agents of the same drug class is limited, precluding firm conclusions about differences in the relative magnitude of risks. Reviewed evidence suggests some agents or classes might carry a comparatively increased risk of RD when used with an opioid, including the Z drugs, especially zolpidem, and the MRs carisoprodol and baclofen. All Z drugs modulate GABA A receptors, which could theoretically potentiate actions of opioids in the central respiratory control center. Zolpidem carries a specific warning for RD, which highlights that RD has been observed in patients who use zolpidem, especially among patients with pre-existing respiratory impairment. Only zolpidem also carries a specific drug interaction with the risk of RD with opioids, versus labeling for most other agents advising about the risks with other CNS depressants in general. After adjustment for other risk factors, an observational study showed an increased risk of overdose among patients who use zolpidem with an opioid. MR's carisoprodol and baclofen may also potentiate GABA actions. One observational study compared the risks of different MRs and found an increased risk of opioid overdose associated with concurrent use of carisoprodol and baclofen with opioids. A neutral or non-significant risk was observed with other MRs such as cyclobenzaprine. Authors of this study suggested that comparatively less risky MRs like cyclobenzaprine or tizanidine could be preferable if concurrent use of an MR and opioid is necessary. Neither of the reviewed pain-focused guidelines nor prescribing information for opioids provided specific guidance on the concurrent use of non-benzodiazepine MRs or SHs with opioids. Other than for benzodiazepines, guidelines tended to address CNS depressants in general and discourage their concomitant use, limiting co-use to situations in which the potential benefits are considered to outweigh the risks. Opioid prescribing information similarly discourages the concomitant use with CNS depressants, with opioid analgesic information recommending that co-use be limited to patients in whom alternatives are inadequate, and opioid cough products generally recommend avoiding use. Guidelines and opioid prescribing information provided similar guidance about mitigating the risks from concomitant use. Recommendations from at least one of these sources included to use the lowest effective dose for the shortest necessary duration and to consider dose reductions when adding a second agent, to provide patient education about the risks and how to monitor them, to consider following up with patients more frequently, consider evolving a pharmacist in the patient's care, and to offer naloxone. Notably, while naloxone can reverse opioid-induced RD, it does not reverse RD caused by non-opioid agents. Concurrent use of opioids and CNS depressants is only one of many possible risk factors for opioid-related RD or overdose, and evidence suggests that risks increase as the number of risk factors for RD increases. Other guideline-recognized possible opioid-related risk factors for RD include using higher opioid doses and use of long-acting opioids or methadone. Owing to a lower risk of RD, the VA guideline weakly prefers the partial opioid agonist buprenorphine to full opioid agonists for chronic pain, although RD may still occur when it is used with a CNS depressant. The SRMA by Wang et al. Highlighted predictors associated with the highest risk of opioid overdose among observational studies of patients with chronic pain, including having a history of opioid overdose, having multiple opioid prescribers or multiple pharmacies, having a fentanyl prescription, filling higher daily opioid doses, especially those exceeding 90 milligrams of morphine equivalents, and having certain comorbidities, including mental health disorders or pancreatitis. So moving on to the data review, we performed a cross-sectional descriptive utilization review to identify the number of Utah fee-for-service patients with at least one overlapping day supply of an opioid with an MR and or SH from April 2023 to March 2024. Included medications were mono-ingredient or combination products with an opioid, excluding buprenorphine formulations approved for opioid use disorder, and the previously identified reviewed MRs and SHs. To describe the duration of co-use of these medications, we calculated the percentage of overlapping days, abbreviated POD, among patient subgroups of opioid with MR, opioid with SH, and opioid with both MR and SH. For each patient, the POD was calculated as the total number of overlapping day supply of the targeted prescriptions during the study period, divided by either the total number of days of opioid supply or the total number of days of Medicaid coverage during the study period. During the study period, 15,888 Utah Medicaid fee-for-service patients filled a prescription for an opioid, MR, or SH at any point. Of this overall cohort, 10,406 unique patients filled at least one opioid prescription in the study period, which I'll refer to as the opioid cohort. About 73% of the opioid cohort patients did not fill any prescription for an SH or MR during the study period. 1,835 patients, which is 17.6% of the opioid cohort, had an overlapping day supply of an opioid with an MR, and 461 patients, which is 4.4% of the opioid cohort, had an overlapping day supply with an SH. 144 patients, or 1.4% of the opioid cohort, had an overlapping day supply of an opioid with both an MR and SH. The median age of each overlapping subgroup was 46 years old, and nearly all patients in each combination subgroup were 18 years of age or older. A high proportion of patients were female, and the median duration of Medicaid eligibility in each combination subgroup was 366 days. Overall, the total median total number of days of overlapping supply in each combination subgroup was less than 1 month. The median number of days of overlapping supply was 13 days in the opioid and MR subgroup, 17 days in the opioid and SH subgroup, and 24 days in the opioid plus MR and SH subgroup. We calculated summary statistics for the individual percentages of overlapping days, or PODs, among each subgroup of patients with overlapping prescriptions. The median POD out of total days with an opioid, in other words, the duration with concomitant overlap compared to the total opioid days supply among each combination subgroup, ranged between about 52% for the opioid plus MR and SH subgroup to almost 96% for the opioid plus SH subgroup, which was higher than the median POD out of total days with Utah Medicaid coverage. While this is expected if the number of days of Utah Medicaid coverage is bigger than the number of days with an opioid supply, it also suggests that on average, patients tended to fill these prescriptions concurrently for shorter durations than their length of Medicaid eligibility. We also assessed which combinations of an opioid plus MR and/or SH were filled, grouping any formulations together with the same active ingredient. The most frequent opioid plus MR combination by patient count was for oxycodone with cyclobenzaprine, filled by 24.4% of patients in that subgroup, and the most frequent combination in the opioid plus SH subgroup was oxycodone plus zolpidem, filled by 34.9% of patients in that subgroup. And the most frequent combination in the opioid plus MR and SH subgroup was oxycodone with cyclobenzaprine and zolpidem, filled by 15.3% of patients in that subgroup. Notably, the top 3 most frequent combinations with SHs by patient count each included zolpidem. Limitations of our descriptive analysis should be considered when interpreting the results. We inferred concurrent use based on prescription fills with an overlap of as little as 1 day, which may not accurately reflect actual patient usage. It's possible that we overestimated the calculated day supply, particularly for patients on a regimen of a long-acting and short-acting opioid of the same molecule. Due to time restrictions, we did not investigate the diagnoses of patients who fill these combinations. This would be our recommended next step to further describe patient indications for these medications. Currently, the Utah Medicaid program addresses concurrent use of opioids with benzodiazepines, but not with other specific CNS depressants. A prior authorization, or PA, is required for use of a benzodiazepine within 45 days of a long-acting opioid and vice versa. The opioid PA also includes providing attestation to educate patients about the risks from concurrent use. If it is desired to assess the concomitant use of opioids with the reviewed SHs or MRs on an individual patient level, we suggest some options to consider. You can refer to section 8.1 of the report for details. Overall, considering the heterogeneity of the overall risk profile of patients who receive these combinations, while also acknowledging potentially legitimate comorbidities and treatment needs, we suggest prioritizing retrospective drug utilization review, abbreviated retro DUR, and our educational interventions over more restrictive population level restrictions. Such programs could target prescribers to patients with ongoing use who are at a higher risk of RD or overdose to bring attention to certain aspects in case the provider is unaware or if the patient is able to modify therapy. Some examples of possible populations that could be prioritized are shown here. such as patients taking all 3 classes concurrently or patients who are using higher opioid doses with higher zolpidem doses. If PA criteria are considered, the caveats of the possible administrative burden should also be considered, and accommodations should be made for patients who need continued access to co-prescribed medications during tapered discontinuations of long-term therapy. PA criteria could request that providers provide a clinical rationale for concomitant use, ensuring that patients are not denied necessary treatment when the prescriber attests that the benefits are considered to outweigh the risks. Criteria could also be more specific, such as requiring provider attestation that the patient has active spasms or spasticity for patients receiving MRs, or that patients with chronic insomnia have failed or do not have access to CBT for insomnia. Another alternative to consider is targeting certain opioid MR or SH combinations, including potentially higher risk agents. Although not necessarily required to implement policy changes, future reviews could gather additional details from the utilization data and/or empirical evidence that we were not able to address in this report. For example, regarding the specific formulations or total opioid doses used by patients filling concomitant therapies, and as previously mentioned, the patient indications for these therapies. So thank you for your time and attention listening to the presentation. Please let me know if you have any questions.
Lauren, thank you. That was a great presentation. I think it, speaks to the amount of work that you guys did reviewing this. Are there any questions for Lauren from the committee?
I do have one. It was, recently the risks associated with the gabapentinoids have been highlighted, and I was just wondering why we didn't include that drug class with this, or if that's something that would be considered for future.
Yes, I have seen that that was highlighted in some of the opioid guidelines that I reviewed. We focused on MRs and SHs just because that was presented to us as classes of interest for this presentation. But I did note that if the board desires, or if the Medicaid team desires, that gabapentin could be reviewed in the future.
All right. Any others? All right. Thank you, Lauren. We appreciate the review.
Can I make a comment or two, Eric? It wasn't a question.
I was going to move to comments. So.
Oh, okay. I thought.
I knew you wouldn't let me down.
No. Well, thanks again for the presentation and the report. It is a very complex issue, right? We have our prescribing side, and then we have the substance use and illicit use side. And another thing that I think adds to the complexity of these adverse events and overdoses and overdose deaths is the use of alcohol, which is not something we can track. In many of the data sets, the mentions of combined overdoses, a significant proportion have benzodiazepines, but a significant proportion also have alcohol. And that's a particularly dangerous combination, right? Alcohol with any of these medications. So I think we have aspects to the problem that we aren't able to analyze as readily as we can the prescription data. So from that side of it, I think there are things that we can do. And I was particularly, I myself, because most of my patients do require opioids and other psychoactive medications. I generally don't prescribe Zolpidem. It's a medication I've been very fearful of for a long time. And I don't think that most people appreciate the risk. I mean, most prescribers, I don't think, appreciate the risks with the Z drugs. So I think that's an area that we might tackle. I think the message has gotten out very clearly, and our VA work has advanced this, that, you know, we really discourage co-prescribing of opioids and benzodiazepines. But I'm not sure that the message is out with other with these other classes. So I think there are some things we could maybe do if there are you know, educational opportunities or review opportunities for the highest risk categories. And lastly, as you know, as I often say, this, you know, this highlights the need for different kinds of mental health interventions. In particular, CBTI, we know, is very effective in the VA. It's quite accessible, and we use it a lot. And you know, to make a dent in some of these issues, I think also, you know, it isn't our I'm not sure if it's our place to recommend non-pharmacologic therapy as the DUR. Anyway, thank you. Thanks for allowing me to share my thoughts.
Thank you. Dr. Britton?
Yeah, does this require us to have a motion for this education, especially for providers that have patients on one or a combination of these medications?
Yeah, I would think if we want to make a recommendation, then we'd need a motion. I think one of the things I was going to ask Noon, does within the adjudication system, are there edits today in place with respect to the concomitant use of any of the drugs in these categories, or is that completely open?
Thank you for the questions. So at the moment, the only edit that we have regarding any muscle relaxant is the accumulations edit within the same class of muscle relaxant itself. There is no edit with the concurrent use between muscle relaxant or sedative with the opioid so far. And as the layout in the presentations, the only edit right now is between the opioid and benzodiazepine. And we will hear from Luis in a minute about his retro DUR interventions that he have done on opioid and benzo.
All right, Luis, you got your hand up.
Thank you. First of all, thank you, Dr. Heath, for that presentation. I was, like Noon said, I am involved with the Retro DUR program, outreach program to providers for patients who are taking the combination of an opioid and a benzodiazepine combination. And the data that I get is updated monthly, and it'll include, you know, patients that have an opioid, a benzodiazepine, and also who do not show an active prescription for naloxone in the point of sale system. And so then I proceed to call the providers. Usually I end up talking to nurses to provide education. And for the patients that need to be on that combination, then the recommendation is to add naloxone, to send a prescription to the patient's pharmacy for that. Now, my question is, I'm calling everyone on my list, right? And so a lot of the patients on my list are patients that have a benzodiazepine and also tramadol. That's a very common one, like 30 MME. So my question is, you know, should I continue focusing on those? Because the presentation that Dr. Heath just presented said, you know, the higher risk of RD is with an opioid of greater than or equal to 90 MME. And so I think I scratch my head and I think, oh, the providers think this is silly when I call them and they're like, yeah, I can add naloxone, but it seems like the risk of RD is low when they're on these lower doses of opioids. But what's your take on that? Anyone? Dr. Weinstein, Dr. Heath?
Well, as I'm sure you know, we're issuing naloxone to everyone on chronic opioid therapy at the VA, and that's been, my practice for a long time. Although, it makes physiologic sense, and we understand from data that higher doses of medications confer greater risk, but the lower doses aren't entirely safe. And I think the thing that was very one of the salient points in the presentation has to do with the patient features. Those patients who are at the highest risk of adverse events have a number of features that, to me, is the constellation of factors that lead to poor medication management and, erratic dosing, concurrent mental health, significant mental health diagnoses. And so it leads me anyway to infer that there is a subpopulation of patients that are particularly at risk. They're not consistent with their dosing, and when the dosing of these combinations is erratic, that's when the highest risk of an adverse outcome occurs. Right? They'll go for a little while not taking much, then they'll dose up quickly, and this is where the respiratory drive is impacted. So there are we can identify patients by their prescriptions, but then I think there's another level of working with the practitioners, the prescribing groups, to say, if you have a patient like this, they probably are not safe to be prescribed. Maybe none of the drugs, but at least not the combinations, and the patients need to be highly educated, right? So I'd be interested to know if we have any death data from this data set that we can use to understand a little bit more about how the adverse outcomes occur. Is there a particular patient population we can identify to really work on to prevent those deaths?
So Lauren, what additional data do you have in terms of the patients? I don't think you looked at any now, but could you look at emergency room visits, overdose, death, and any of those kind of things? Do you have those data points?
We did not look at any outcomes associated with these use, so we didn't look at emergency room visits for overdose or deaths, but I believe that we would be able to look at outcomes such as that if there is interest.
So, and I guess my question for the committee is, given the lack of resources, and Luis is one person, and we're using valuable resources to make outbound phone calls to physician offices. Is there a need to take some of what he's doing, prioritize it in terms of those patients most at risk? And I think Dr. Weinstein, you did a great job kind of elucidating, these patients with mental health problems and other things. But is there more of a algorithm, so to speak, that now beyond just opioids and benzodiazepines starts to include the sedative hypnotics and some of the muscle relaxants, really directing those resources and that time and energy at those patients most at risk?
I mean, Dr. Siegfried.
I'm sorry, Dr. Weinstein, but I know a lot of providers seem to feel more comfortable prescribing tramadol, zolpidem, and gabapentin because they feel they're less likely to cause adverse outcomes. Although I've seen all three abused. And the other question I had that may be something to consider is whether these prescriptions are all coming from one provider or more than one provider, because there's often not good communication between providers, or even knowledge that patient may be receiving this combination of medications, because of lack of provider contact.
Yes, in my experience with calling providers, most seem to be aware of the combination, but there are a few sometimes that are like, "Oh, thank you for letting me know," and then that's when I provide additional education on, confirming before prescribing controlled substance to check the controlled substance database to look for multiple prescribers.
Dr. Britton?
This is probably a dumb question because I work inpatient, so I'm not, looking at that database. Would it have all these meds on it? I mean, I typically, when our team's looking at the things, really should try and look at the benzos and the opioids. Does it cover all the prescriptions? And so these would show up as well?
The muscle relaxants probably won't show up. But you would get anything that's controlled, and so tramadol, gabapentin, zolpidem, hydrocodone, oxycodone. So there are some of these that we've discussed this morning that wouldn't show up in that database. What I'm, this is just Eric thinking out loud, but is there an opportunity that the state could sit down and say, here's a plan by which we can, educate providers, and maybe there's broad education in the form of letters or something that goes out initially, or articles in their regular newsletter that's disseminated, and then kind of beneath that is an algorithm where high volume physicians are identified, those with lots of patients, there's a direct outreach. I just think in 30 minutes we have left, we won't put together what that outreach plan ought to look like, but I'm wondering if in terms of the committee, that's a recommendation we might make, that the state put together an outreach plan around these drugs that, further in, the use of concomitant opioids, sedative hypnotics, muscle relaxants are then incorporated into the work that's already existing with opioids and benzodiazepines.
We can definitely, like, every month or quarterly, the state does publish the Medicaid bulletin informations, and that is where most of the educations or updated on our policies go out to the provider. And if the board make the recommendations, we can consider input that in the mid as an educational piece. And further discussion will be needed if this is something that we can implement it or incorporate into the retro DUR that Louise already been doing between the benzo and the opioid. That to take into considerations.
Okay, and then Dr. Weinstein threw a comment out there that, people being co-prescribed by multiple prescribers going to multiple pharmacies, those are the higher risk, and are actually exhibiting behavior that, some may not be intentionally doing that, but probably a significant number of them are. And so, that may be another way to kind of educate providers about the controlled substance database.
Louis, is that something that you already do between opioid and benzo?
Yes, when I get that list, the monthly updated list, I do look at the controlled substance database for each one of those patients and note the prescribers, the multiple prescribers for benzos and opioids, and then I send a letter to each one, kind of letting them know this is your patient and these are the prescribers currently involved and what they're prescribing.
And at the additional effort on top of what Louise has been doing is showing our PA review. When we reviewing PA for either opioid or benzo that came through our system, and looking at the controlled substance database, and if we notice the two different prescriber prescribe separate opioid and benzo, we also send, if we are denying that request because of the concurrent use, the provider also receiving on our notice that there is somebody else prescribing either opioid or benzo to the same patients as well.
Okay. Other thoughts, comments? With the committee's approval, I would recommend that the state put together a plan to incorporate these into the current processes and prioritize so that Luis is using his time and energy for the highest priority patients.
Well,
Anybody?
so moved, Eric.
So we have a motion. Do we have a second?
Second.
All right. All in favor of the state reworking their plan and including these in Luis's work, say aye.
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 I,
Any opposed? All right. Then, Luis, you guys have got, you've got our direction. So, moving on, we have Kiza listed. Noon sent out a proposed prior authorization criteria, so Noon, we'll turn this over to you now.
Thank you. And thank you for the recommendations and motion from the board. So this is regarding the IKIVZA. And I also sent with the email from last week was the prescribing information for IKIVZA as well. Sorry, 1 second. So a quick cap of IKIVZA is this is the medications that is used as an IV dosing monthly. The indications per FDA is to use as an adjunct to other low-density lipoprotein cholesterol lowering therapy for the treatment of adult and pediatric patients 5 years of age or older with diagnosis of homozygous familial hypercholesterolemia. The medication is an inhibitor monoclonal antibody. The criteria for approval is one of the following criteria must be met. Is the patient at least 5 years of age? Does the patient have a diagnosis of homozygous familial hypercholesterolemia? Is the patient currently treated with other background HOFH therapy and is unable to reach the LDL goal at the maximum tolerated dose of background therapy? We asking for the LDL goal. We asking for the LDL level while on the background therapy and the detail of the background therapy and any detail of the failure of the background therapy. Additional question is if Ikiza being used as an adjunct to maximal tolerated dose and intensity statin therapy, Zetia or BCSK9 unless contraindicated or serious adverse event. The readout criteria is, has the patient had clinically significant improvement as shown by the specific appropriate monitoring parameter and or improvements in symptoms? Is LDL is now at goal, or if the patient has at least 30% reductions of LDL from the baseline? Does the patient continue to receive concomitant lipid lowering therapy at the maximum tolerated dose or have an intolerant or contraindication to other lipid lowering therapy? Few things to be noticed. This is the new format that the state is moving forward into having the provider answering yes and no questions to each of these criteria. And then the criteria were designed based on the clinical study of the Ikiza. As in the clinical study, all of the patient is on the background therapy when receiving Ikiza. 30% requirement reductions for the retro art is also lowering than the mean change in the primary endpoint of the percentage change of the LDL from baseline. In the first clinical study, the mean change in percentage was 49%. The second study was 52%, and the third study was 48%. So our 30% was reasonable. And open up for discussions and questions. Let me try to just one page.
All right, any comments from the committee? So then I'm assuming the approval only happens if the patients have failed all other therapies. Am I correct?
Yes, as is, the indication is to use it in adjunct with the other therapy. So if the and per the at least per our research, that is the others is still the first line therapy. So we would like them to try other therapy first before going on and use this in additional to the background therapy.
Okay. I mean, I think the criteria looks reasonable to me. Dr. Smith, you had a comment?
Yeah, under therapy, do we want to clarify drug therapy to make sure they don't think we're also talking about lipoprotein apheresis?
Thank you for that. Yes, I added on the background drug therapy.
Any other comments from the committee? All right. Speak now. Do we have a motion for approval?
Move approval.
Do we have a second?
Second.
All right, we have a motion from Dr. Weinstein, and that was seconded by Dr. Hoffman. All in favor, say aye.
Aye.
Any opposed? The motion passes. That's the last item on our agenda today. Thanks for playing. Next meeting is on July 11th, and we'll be talking about concurrent use of stimulants and sleep aids. everybody stay cool through the end of the week. It looks like we get some relief next week. So have a happy day, everybody. We'll catch you on the next meeting. Thank you.
Thank you.
Thank you.
Thanks.